Good morning, and thank you for joining us this morning for our presentation on the physician's role in promoting healthy hearing throughout the lifespan. I am Dr. Esther Fogel, and I am honored to be hosting our guest speaker, Dr. James Hall, whom I will be introducing shortly. Welcome to all of you physicians and healthcare providers who are joining us live today. Just a few technical details before we get started. This presentation is being recorded, and the recording will be available for anyone who is unable to attend. Please keep your microphones muted during Dr. Hall's presentation. If you have any questions, you can type your questions into the chat box. There will also be an opportunity to ask questions live at the end of the presentation. Next. I would like to take a moment to introduce myself and my audiology practice. My name is Dr. Esther Fogel. I am an audiologist and the practice owner of Comprehensive Audiology located in Lynbrook, New York. At Comprehensive Audiology, we partner with primary care physicians to provide personalized hearing care to meet the needs of your patients across the lifespan, from pediatrics, infants, to adults and geriatrics. Hearing loss can affect your patient's overall health and well-being, physiologically, socially, emotionally, and cognitively. We take the time to get to know your patients and offer a customized hearing solution using our state-of-the-art diagnostic equipment. Our focus is personalized patient care, offering the latest in hearing technology and hearing protection. We accept all major insurances and offer convenient hours and scheduling to address your patient's needs. Next. Here's our mission statement. At Comprehensive Audiology, our goal is to provide our patients with personalized care so that they can experience better communication through better hearing. By utilizing our state-of-the-art equipment and the latest hearing technology, we are changing lives one patient at a time. Next. It is now my honor and pleasure to introduce our guest speaker, Dr. James Hall. Dr. Hall is an internationally recognized audiologist with 40 years of clinical, teaching, research, and administrative experience. He received his PhD in audiology from Baylor College of Medicine. During his career, Dr. Hall has held clinical and academic positions at major medical centers and leadership roles in the American Academy of Audiology. He is the author of over 200 peer-reviewed publications, articles, and book chapters, plus 12 textbooks. All of us in the field of audiology and hearing sciences have read at least one of Dr. Hall's articles or textbooks in our career. Dr. Hall now holds academic appointments as a professor at Salus University and the University of Hawaii. It is now my pleasure to turn the mic over to Dr. Hall.
Thank you very much, Esther. I hope everybody can hear me clearly. I'm really pleased to be giving this presentation early this morning, and I thank those of you who are online at this time, listening to it live, and also those of you who are going to join at some later time and listen to the recorded version. Much of what I'm talking about today will be focusing on what physicians need to know about hearing, both of children and adults, and really to encourage physicians to think about referring patients to an audiologist when they're at risk for hearing loss. And of course, as an audiologist, I strongly encourage my colleagues in audiology to refer patients to physicians who have some risk factor that physicians can effectively manage. Most of the information in my presentation is actually in this article that you see here, Promoting Healthy Hearing Over the Lifespan, which I published in 2021. And I'm more than happy to send you a copy of this, a reprint, if you send me an email at the email address at the top of the slide. If you Google my name, James W. Hall, and definitely put in the third, then you will come to my website and you can easily find many of these articles if you forget the email address. Okay. Now, I didn't know how many physicians would be pediatricians or family physicians that might be providing services to children versus those who were mostly seeing adults. So I've included a little bit of the topic on focusing on children and adults, more on adults. But let me talk about the risk factors for hearing loss in children. These are indicators that a child really needs to have a hearing assessment if they're not already under the care of an audiologist or have not yet been evaluated. And these are all evidence-based, and we'll just quickly go through some resources for information that you could have in your office to explain to parents or whomever, nurses, why you're referring patients to an audiologist. As I think all of you know, there's an interdisciplinary group called the Joint Committee on Infant Hearing. The Joint Committee on Infant Hearing, actually, there have been many versions of it since the 1960s. The most recent position statement, which is totally evidence-based, it's a clinical practice guideline, was published in 2019. And these are just some of the disciplines, some of the professions that have representation on the Joint Committee. So you can see it's physicians, audiologists, actually some parents, some statisticians, ethicists, people who are focusing on people with hearing impairment and deafness. And so this is a great place to go for evidence-based risk factors. They've done the research, and really all you need to do is have a copy of this, which you can easily get online, and particularly have a copy in your office of this table 1, which lists 12 risk factors for hearing loss in children. And although the Joint Committee is focusing on infants from birth to 2 years, it really applies to any child. Family history is obviously a risk factor, and it's kind of simple to identify, but it's probably one of the least identified risk factors. People don't ask about family history of childhood hearing loss in the parents as often as they should. And then we're not going to go through all of these, but you can see there's hyperbilirubinemia. Just being in an intensive care nursery for more than 5 days is a risk factor. Low APGAR score associated with asphyxia. Any kind of drug that might be ototoxic. Any kind of infection too, in utero or after. So where infections like cytomegalovirus, actually, that's one of the more serious causes of hearing loss in children, and it can be progressive right into school age. So those children definitely need to be followed. And then any kind of craniofacial anomaly, even little tags or sinuses or little pits near the ear, or more obvious congenital problems like cleft palate, for example. And then, believe it or not, there are over 400 syndromes associated with hearing loss. So any child essentially with a syndrome really should be referred to an audiologist for a comprehensive assessment of hearing at any age, whatever the child's age may be, from a couple days old to a teenager. Any kind of infection in the childhood, such as meningitis, is a big risk factor. And then, of course, head injury of any type. Many times there'll be a child will fall out of bed or have some type of head injury. Very seems to be minor, no real serious loss of consciousness, but there could be damage to the temporal bone. There could be damage to the auditory system. So that child should be referred. And chemotherapy is another big one. Certainly any chemotherapy that includes cisplatin, which is extremely ototoxic. And then finally, number 12 is probably the most important, and one that all of you can implement in your office. And that is simply asking the parents or caregivers if they have any concerns about hearing or communication or speech and language development. When an audiologist evaluates a child, it's a pretty simple procedure. It's non-invasive, essentially hearing games for the child. And we can evaluate any child of any age. So you should always just think of referring a child who's never had a hearing test or who may have a risk factor that has created a hearing loss, even though they passed a hearing screening at birth. Just send them to the audiologist. That's my main recommendation. There's no harm in doing that. And very often that'll lead to early identification of a hearing loss, early diagnosis, and early intervention. Now, we're going to move out of the young children category into adolescents, teenagers. In recent years, you may have seen articles or had read health articles in like the New York Times. That's where I heard about this article, about the increased prevalence of permanent hearing loss in teenagers. And it's a real phenomenon. This is an article published in a British journal, which got a lot of attention in the media, showing that over 1 billion young people, teenagers, are at risk for hearing impairment. And it's almost all music, some noise, but almost all music. And then here's another, this is an older article, about 10 years ago, which got a lot of attention also. It's in JAMA, and it basically showed that the prevalence of hearing loss in teenagers is close to 20%. 1 out of 5 teenagers has some degree of hearing loss, and most of these people passed hearing screenings at birth. So this is acquired, and it's all pretty much associated with exposure to noise, but particularly music. So when you're evaluating a teenager, if they've never had a hearing evaluation, if they're in the band, if they listen to iPods and music, make the recommendation at least to rule out a hearing loss. Now we're going to move into risk factors for hearing loss in adults. And I'm going to talk about these 3 major categories: advancing age, which is age-related hearing loss, but it's not due to the age itself. There are other factors involved, and we'll cover those, particularly comorbid conditions and lifestyle factors. And then I'll cover the last 3 topics at the end, and I will leave time for questions and answers. Well, it's been known since the development of the first audiometer back in the 1920s that over the lifespan, most people will lose some high frequency hearing. And now we have, of course, extensive data on that, how that process evolves. And usually by 40 to 50 years old, somewhere in that age range, maybe early 50s, there'll be some slight decrease in the highest frequencies. And this is permanent hearing loss due to inner ear dysfunction. Now, it occurs for males and females, but there is a slightly different pattern, at least historically there has been. And with the males, the high frequency hearing loss is showing a little bit of a dip at around 4,000 hertz. If you look at this graph here, the frequencies on the x-axis, so the higher frequencies are to the right, and hearing loss, greater hearing loss is down, not up. So 0 dB would be perfectly normal hearing sensitivity. And so the difference between the males and females really suggests that in the males, some of this age-related hearing loss is really due to noise exposure. But there are many other factors that are involved. Now, I want to make a very important point right here. Age-related hearing loss is not inevitable. And as I said a moment ago, it's not because somebody's 70 or 75 that they have a hearing loss. It's because of all the things that might have happened to their ears throughout their life, up to getting to the age of 70. So we need to look at those factors because we might be able to prevent most age-related hearing loss. And actually, we are able to do that. If we identify a child or a teenager, and from that moment on, manage their health and keep them healthy, make sure that they live a healthy lifestyle, deal with any diseases or disorders, keep them from getting diabetes, for example, and cardiovascular disease, we have a good chance of actually preventing or at least mitigating hearing loss for their whole life. So much of age-related hearing loss is not inevitable, it's preventable. Now this graph, and I'm not going to get into a lot of data, I'm going to mostly emphasize major points, but this is kind of another one of the major points that I want to make in this presentation. These data are really quite interesting. A couple of audiologists, Ian Windmill and Barry Freeman, you see their names there, they collected data from Medicare patients. So these are patients age 65 and older, over 1 million of them, and said, okay, if patients go into an audiologist, what kind of health problems do they have? So they looked at, these are all documented, diagnosed health problems in older people going to see an audiologist. And they found that there were a number of comorbid conditions that are associated with hearing loss. Now, these are just connections, in the Medicare data, but we're going to actually show you in a moment systematic reviews and meta-analyses confirming each and every one of these comorbid conditions. So let me just quickly put them into categories. We've got the, you might say, the cardiovascular disease or disorders. So the first, very top category here, the very first on the left is hypertension, high blood pressure, and we've got others, stroke, for example, heart failure. And then if you look, there's some other categories. There's rheumatoid arthritis. Many of you probably didn't realize that's a risk factor for hearing loss. There's high cholesterol is another risk factor. Diabetes is huge. That's probably the one systemic disease that you need to worry about most when it comes to hearing. And then we could have another category of the cognition and dementia and cognitive function disorders. And they are definitely related to hearing. So let's dive a little deeper into some of these comorbid conditions. First of all, it's really getting a lot of attention. This is a journal, an audiology journal, the International Journal of Audiology, which is one of the more respected and, of course, obviously an international journal. And this is a study from Europe, but there are many others from the United States, from around the world, emphasizing that audiologists must consider comorbid conditions in managing patients. And I would argue that physicians also should consider hearing when they're addressing the health needs of a patient with these comorbid conditions. So let's just run through them quickly. And I'm going to cite many articles, which you can easily find on the internet, to document that what I'm saying is not just hypothetical, it's not experimental, it's not somebody's suspicion. This is really hard data that's been proven. The connection between these problems and hearing is well established. Now, to be honest with you, I've been an audiologist for over 40 years, and it wasn't until the last 3 or 4 years that I was aware that high cholesterol actually is associated with hearing loss. And the reason I actually started reviewing the literature is I only take one medication. I'm 74 years old, and it's atorvastatin. And my parents each had high cholesterol, and there's not much I can do about it. I tried eating Cheerios and everything else, and it just didn't work. I'm very active physically. I have to have some medical management. So I started to ask myself, oh, geez, I wonder if high cholesterol, or perhaps the drug, such as a statin drug that is used to treat it, might be associated with hearing loss. Well, it turns out, just the bottom line is, hyperlipidemia is definitely associated with hearing loss. And when it's managed properly with a drug like atorvastatin, that minimizes the risk. So that's something that every audiologist should be aware of, and every physician. And that literature is quite extensive. It's all recent. If you look at the dates here, we're talking about the last 10 to 15 years at most. Diabetes, I've already mentioned it. The research on this is extensive. I mean, there are literally hundreds of articles linking hearing loss with type 2 diabetes. And the longer the person has the diabetes, the more at risk they are for hearing loss. And this is being studied extensively around the world. So these are data that are well established. This is just one of many articles. I could talk about any one of these comorbid conditions for our entire 45 minutes. And then, of course, these comorbid conditions, you're all aware of this, that I'm talking about, like diabetes, for example, very often may be associated with other health problems aside from hearing. For example, this is a study linking hearing loss in people with hypertension. So that's one of the cardiovascular disorders, with diabetes in the elderly. And so what happens, the more risk factors a person has, the less healthy they are, the more physicians they're seeing for health problems, the more likely they are to have a hearing loss. Now, I mentioned a moment ago rheumatoid arthritis. I mean, this is another comorbid condition that I wasn't even aware of until I started reviewing the literature. Now, this is a little bit tricky, and this actually really applies to some of the comorbid conditions. There is definitely association between increased risk for hearing loss in patients who have rheumatoid arthritis. And again, the longer they've had that diagnosis, the more at risk they are. But nobody knows exactly what the mechanism is. It may be inflammation that's affecting hearing through the ear, but it may also be the management of rheumatoid arthritis, and some of the medications the patient takes might also have some ototoxic effect. But regardless of the mechanism and the details, the important message is, if you have a patient who you're treating or who you know has rheumatoid arthritis, they need a hearing test, and they need to be followed audiologically. Here's another one, quite removed from the ear and the head and neck, COPD. But it makes sense, of course, if a person's not getting the proper amount of oxygen, they're going to be at risk for any type of deficit in any tissue, including the ear. And the ear It turns out, we know this from research in people with head injury and comatose patients and intraoperative patients, that if there's a little drop in oxygen or blood flow to the ear, it's very sensitive. The ear needs to have constant flow of blood to the hair cells, which are highly metabolic. So it doesn't take much of a drop in oxygen levels to end up with either a peripheral hearing loss affecting the ear or a problem affecting the brain itself. And these, again, here's another systematic review and meta-analysis. So you can count on these results. They're very, very solid. And then patients with kidney disease, another disorder that wouldn't seem to be connected to the ears. Or it turns out that in the ears, there are some stereocilia, some cilia. They're very much like what you find in the GI tract. And the kidney disease is really closely related to hearing, and particularly people who are on dialysis. And it makes sense. We know that people who are getting ototoxic drugs tend to have hearing loss or be more at risk when the kidneys aren't functioning normally. So here's another group of patients and another group of physicians, nephrologists, for example, that should be, and neurologists sending you patients, or audiologists should be communicating with those specialists. Now, here's a comorbid condition that literally I could talk about this for hours and hours, but don't worry, I won't. I'm keeping an eye on the clock here. And that is hearing loss and cognition. Now, obviously, some degree of cognitive function is necessary for hearing, but this is research that dates back a little more than 10 years to about 2010, 2011. And it was research showing that people, older people in particular, who have long-term hearing loss, which is not being managed properly, they're not wearing hearing aids, for example, are more likely to have cognitive decline. It was a little controversial, even though the first article by this fellow here, Frank Lin, was out of Johns Hopkins. It was a very good study, but there was a lot of controversy about it. And he basically just put this idea out there. Well, in the last 10 to 12 years, this connection between hearing loss and cognitive function has been proven over and over and over. And we're going to go through some of those studies. So the first message is, if you've got a patient of any age, but if they're getting up to 45, 50, 55, they need to have a hearing loss. If they have a hearing loss, it really needs to be managed properly. The brain needs to be getting constant stimulation. The person needs to be interacting with others, communicating effectively, not isolated because of a hearing loss. And that will have a great beneficial effect on their long-term cognitive functioning. Conversely, if a person has cognitive decline and that's already known and they're sent to an audiologist, that process can be slowed or even arrested by proper management of hearing loss. So that's just talking about peripheral hearing loss that we normally tend to think of, not being able to hear faint tones, particularly in the high frequencies, hearing loss that affects the ability to hear speech on cognitive functioning. But it goes beyond that. We know that if you go to a skilled nursing facility, for example, and this has been done, and you have a bunch of people, by definition, most of them will have cognitive decline and dementia, you'll find a very high percentage of people with hearing loss. In fact, it's hard to find someone who doesn't have a hearing loss. So we know that hearing loss is not just a risk factor for cognitive decline, but also dementia. Every time you have a patient with memory or attention problems, a patient who's distracted, who's not able to function in their normal day-to-day activities, they should be sent for an evaluation. And sometimes, on occasion, what is thought to be dementia or severe cognitive impairment actually is a hearing loss. Now, audiologists have some very simple tests that can be administered in 5 or 10 minutes to detect whether or not there is a cognitive factor involved in communication. In other words, whether memory, attention, processing speed, for example, are affecting the person's ability to understand what other people are saying, particularly in noisy environments and adverse environments. So we know, and this is another meta-analysis and systematic review, that if you administer to a person, let's say Esther's 30 years, 40 years from now, she comes into my office and I say, you mentioned having trouble hearing people in a restaurant or when there's background noise. We're going to do a test of speech perception and noise. I do it on every patient I ever see. It's just routine. I might find there's a deficit in this person who's coming in, they're not really being managed by a physician for cognitive function. And I might say, based on the history and my finding of poor speech perception and noise performance, I'm going to refer this person to a psychologist or back to their physician, or perhaps even to a neurologist for further cognitive evaluation. And you will find that one of the earliest indicators of cognitive impairment, before anyone knows what's going on, the patient, physician, family members, is a deficit in speech perception and noise. So here's a way where an audiologist can actually help you and your colleagues in early detection of cognitive decline, with the goal of maybe preventing dementia altogether. There's some wonderful review articles that I'm going to refer you to on this topic. Again, I could go on and on, but we don't have time. Here's one of them, and this is just 2021, so it's basically a year old. Hearing and dementia from ears to brain. The journal Brain is one of the more respected journals. So this is the 144th issue, so you can see it's been around for many, many years. So I encourage, and this is free online, just go to PubMed and you can download a PDF version. And now we're going to move beyond cognitive functioning and dementia to another very common comorbid condition. And that is the combination of a vision problem and hearing problem. Now that can occur in any person, including children. There are certain syndromes like Usher syndrome, for example, or Pendred syndrome, which involve both vision and hearing. But I'm focusing mostly on vision deficits with aging, presbyopia, and hearing problems with aging, presbycusis. And these are dual sensory impairments. Now you can have other sensory functions involved, balance, vestibular function, for example, but we're just talking about vision and hearing. And to be honest with you, you could walk down on Fifth Avenue and stop 100 people over the age of 60 or 65. You're probably not going to find more than a couple that don't have at least some problem with their vision. It may be properly managed, but some problem with their vision and some problem with their hearing. I mean, this is extremely common. And what can happen is either problem, vision loss or hearing loss, creates its own set of difficulties. But when you combine them, it becomes much more serious, and the impact is much more serious on the person's life. So it's very important for all of us, including we audiologists, we're focusing mostly on ears and hearing, to always consider the eyes and vision and make sure the patient's being properly managed for any eye disease or vision impairment. And one of the big reasons for doing that is not just to help the person function more effectively in their day-to-day life, but there's now solid evidence. Here's another systematic review linking dual sensory loss, age-related vision and hearing problems with mental health. So a person who's got untreated hearing loss, an older person, and whose vision is also not being properly managed, who has a vision impairment, is much more likely to be depressed, clinically depressed. And it's a horrible thing because it could easily be dealt with by proper care of vision and proper care of hearing. Okay, those were all comorbid conditions, mostly diseases, and most of them systemic. But now and some people might say, if I'm talking to a patient, I might say, oh, look, my family's always had diabetes, high cholesterol, there's nothing I can do for it. They almost have a fatalistic, there's no way I'm going to keep my hearing. I'm going to lose my hearing like my family members did. But there are other factors that I always ask about in my history and talk to a patient about that they have control over, that they can manipulate. And these are lifestyle factors. So I'm going to talk very, very quickly about 4 of them. One is diet, or what a person eats. Excuse me. And as you know, there are indices, ways of assessing somebody's quality of somebody's diet, whether they're healthy eaters. One is the healthy eating index, which has been criticized for focusing too much on dairy products and meats, but it's very easily available. So you could have the patient complete it, and you can look at the results as they're sitting in your office and saying, you really need to work on improving your diet, more vegetables and more healthy foods and less carbonated beverages and less sugar, et cetera. So that's one. The one right below is exercise. And as I think all of you know, the more we learn about exercise, the more we realize it impacts every aspect of health, including cognitive functioning. The third is smoking. And we're going to cover these each in a moment, but smoking, the bottom line is it's horrible in so many ways, but in terms of hearing, it's probably the worst thing that a person can do to put themselves at risk for hearing loss and related problems such as bothersome tinnitus. And then the fourth lifestyle factor is hearing protection, making sure that the person is not being exposed to potentially dangerous levels of sound. So let's quickly run through these. This is from a colleague of mine who has a master's degree in public health, as well as two audiology degrees, a PhD and a doctor of audiology. His name is Chris Spankovich, and we've spoken on tinnitus quite a bit together, and he uses this slide, so I'm borrowing it. So it's a very easy way to remember these mnemonics, what is healthy and what is not healthy. And the research on diet and hearing is extensive. Just as I've discussed systematic reviews and meta-analyses for other topics, there's plenty of articles on this topic. Here's one of them. The first author is Christopher Spankovich, where they're going back looking at data that's from the National Health and Nutrition Examination database, which is enormous, and people are mining that data, showing that the better the diet, the healthier the person eats, the less likely they are to have bothersome tinnitus, and the better their hearing. And this has been proven over and over. So diet, a discussion about diet, and an assessment of diet should be part of every audiologist review of a patient's history, as well as physicians. Here's another great article from England, the UK. There's been a lot of epidemiological research there showing a direct relationship. The poorer the diet, the longer the person's had a poor diet, the more likely they are to have a hearing loss. And some modifications in diet, relatively minor, like higher vitamin D intake, can have a very beneficial effect on hearing. Okay, I mentioned smoking and how horrible it is for hearing, and obviously health in general. And that's been proven as well with formal research. And it's just beginning to be appreciated in the last 5 to 10 years. So here's one of the articles on the effect of smoking on hearing that you could easily find online. Here's another, again, from the UK. I know several of these authors, and I've talked to them about it. These are superb studies on very often hundreds of thousands of subjects. Cigarette smoking, passive smoking, which is also a problem, and that not just for adults, but for children. So passive smoke inhalation by children can be a risk factor for a lot of things, from otitis media to even permanent hearing loss. And then alcohol consumption. Turns out, I know, again, some of these folks, and I was curious to know, I knew that smoking was very risky, but what about, say, drinking beer or wine? And it turns out it's really the smoking that's a problem. In fact, modest alcohol consumption can sometimes actually offset the negative effects of smoking. So your emphasis in talking to patients should be, if you're dealing with a smoker, and particularly a younger smoker, 20, 30 years old, if you can get them to stop smoking, you've given them a huge gift in general, but also for their hearing. And then noise. In music, I should point out that we always talk about noise, but for many people, the real risk for hearing is not noise, it's music. So I really refer to this usually as recreational sound exposure. So it could be anything from using a skill saw, riding a very loud motorcycle, which of course doesn't need to be loud, shooting rifles or pistols, amplified loud music, or wearing, most commonly with children or young people, adolescents, wearing audio players. So how do you know that a person, one of your patients is being exposed to high intensity sound? You're a physician, you're in a typical exam room, you don't have an audiometer, you don't have a sound booth. How do you know, if you're just trying to get a quick feel for whether this patient could be putting their ears at risk? All right, well, if what I do is say to the child or the person, you like to wear earbuds, you like to use your personal audio player, why don't you put one of your songs on that you really like? Just say, I'd like to hear the music you're listening. Just put it on the way you normally listen to it. or the way it was before you came into my office. And then try to talk to them while they're listening to the music. If they're shouting to you so they can hear themselves, they're listening to music that's too loud. If you say, do you ever hear some ringing sound or buzzing sound or hissing sound after you listen to music? They say, oh yeah, but it usually goes away. That's another risk factor. And then find out how long they are exposed to high intensity sounds, because we know there's a time intensity trade-off. And if they're at very high intensity levels, at which you can easily generate with many ear level earbuds, say 110, 115 dB, you can't really listen to that for more than 10 to 15 minutes without a danger. So those are simple little ways, strategies that you can determine whether someone's at risk for high intensity sound exposure. All right, we're getting down to the last few minutes here before we take questions. And if you have questions, by the way, just use the chat feature to send them to Esther and she'll compile them, and then I'll address them at the very end. Okay, well, I've kind of given you a little hint as to how you might screen for hearing in the physicians in your office. But here's some other information, which is very, very practical. First of all, you might want to take a look at your history, patient history, or add another page which focuses on the kind of questions that we were addressing in this lecture. For example, ask about sound exposure and emphasize the music. And it could go way back. You'll have sometimes a 65, 7-year-old, and they say, well, yeah, I was in the Army back when I was, in my 20s and teens, but I haven't been around noise since then. Well, once there's damage to the ears from noise, it's permanent. And very often, as a person ages and these other age-related factors interact with that early noise-induced hearing loss, they can have a more serious problem than they would if they'd never been exposed to noise. Ask about the lifestyle factors in your history. Definitely smoking. Try to find out more about their diet, and then get them to tell you a little bit about their exercise. Because remember, these are all manipulable. You can change these. If a person stops smoking, by the way, even if let's say they're 60 years old, they've been smoking for 30 years, they may say, well, there's no sense in stopping. It's not going to help me. The research that I've just cited clearly shows that people who stop smoking, the hearing risk stops. They don't, and sometimes actually, if they exercise after they stop smoking, improve their diet, hearing will actually improve. And then ask about related problems in your history: tinnitus, bothersome tinnitus, balance problems, etc. They may indicate a problem with the ears. Of course, ask about the comorbid conditions. And then anyone over the age of 50 who's in your office who has not had a formal hearing test, or perhaps not since they were a child, automatically, let's get a baseline audiologic assessment. And if they have any of these risk factors that we've talked about for central nervous system problems, cognitive function, cardiovascular problems, then make sure that that hearing assessment includes a measurement of speech perception and noise. And then you could conduct a formal screening right in the office. Now, how would you do that? You're not going to buy an audiometer. That's not a very effective way to screen. A simple hearing test with pure tones is very insensitive to problems in the ear. It's time consuming. It doesn't give you very much information. A better option would be to use a technique such as otoacoustic emissions. Now, if you want to know more about it, I can recommend a great book for you, the one on the right. But this is a screening test that's used for newborn infants. It's a measurement of how well the inner ear is functioning, and particularly the outer hair cells within the inner ear. The outer hair cells are, and by the way, this equipment's quite modestly priced, so that's not a prohibition. You present a sound to the ear canal with a little probe. The energy goes through the middle ear, from the eardrum on in through the middle ear to the inner ear, and then it activates the outer hair cells, which start moving. In this diagram, that's abbreviated OHC. They start moving up and down. They're capable of motility, and they generate a little energy, which comes back out. That's the arrow going outward to the outer ear. So in a matter of 30 seconds to a minute, we can find out whether a person's ear is functioning normally. And almost everything that can go wrong with an ear, almost all of the problems I've been discussing, will affect the outer hair cells. They're like the canary in the the coal mine. They are the first part of the ear to be affected by any kind of insult of any type. And so if the person has a problem with their otoacoustic emissions, and it'll just tell you, I'll show you right here, you put the probe in the ear, you press a button, 30 seconds to a minute later, you've got a message on the screen, pass or refer. That's all it is. You do that for each ear. You're totally justified in sending any patient with a refer outcome to an audiologist. There's something wrong with the ear. They may not have a hearing loss yet, but there's something wrong with the ear. And there are CPT codes, there's 3 of them for otoacoustic emissions. This is the one, 92587, the screening CPT code, which you could easily use in your office. All right, we're going to wrap up by just kind of emphasizing that physicians and audiologists should be communicating all the time. They should be referring patients to each other, and they should understand what impact risk factors, comorbid conditions, lifestyle has on hearing, both the audiologists and the physicians. So as I've mentioned throughout my talk, audiologists should be interacting not just with otolaryngologists, or not just with pediatricians, but with all medical specialists, from family physicians to endocrinologists, for example, and a nephrologist and ophthalmologist. And physicians of all types, all specialties, from primary care to subspecialists, should be thinking about hearing every time they evaluate a patient and referring patients to audiologists for a comprehensive diagnostic assessment if they're at risk for hearing. Okay, we've got a few minutes for questions. So I'm going to ask Esther if anyone has posted one through chat.